Good morning. I'm Jorge Alió, and I'm going to summarize which were the different presentations that we had yesterday in the special session entitled What's New in Eye Research and Clinical Care, and we deal about anterior and posterior segment topics. Most of the speakers are not here, and so I will summarize one by one the different talks that we were having yesterday. I was co-chairman with Prof. Barraquer from Barcelona. He's not here either, so I will summarize all the talks. And they were the protagonists yesterday of the different talks. The first was Juan Álvarez de Toledo, who dealt about the topic of cataract surgery in the neuritic eye. He saw that cataract is almost universal in the neuridia, and also the malformations of the crystalline lens, which are less frequent, are giving trouble to a minority of cases, but about 30% of them have a malposition of the lens. So it's not only about the cataract, which is universal, but a certain percentage, which is significant, has a lens malposition, and a minority has a lens malformation, which is macrospherophakia. He deal about the indications of the surgery. The surgery in aniridia should be performed on a special basis because it is an opportunity not only to restore vision and refraction, because with the adequate calculation of intraocular lens we can eliminate the glasses of the patient. That is a benefit or extra benefit for the patient to be adapted for low vision aids, which are so much useful in many cases, but also to use, if possible, artificial irides. Artificial irides were a debate yesterday because with the ones that were more in use, which were one German company, another from Russia, both are out from the market. One because the company decided for unknown reasons to cancel the production, while the other is obviously not available today with the European conflict that we have. So we are left only with one more company, which is a German company called Human Optics, that manufactures quite a nice model cosmetically of iris replacement and iris made on silicone that had to be managed with special care and for highly specialized surgeons, because it's not easy to manage, even that is providing good results, and had to be attached to an intraocular lens that has to be enclosed to it in order to provide the adequate correction to the refraction. In other words, it's a double surgery, a little bit more complicated than we had before, because the previous implants, especially the implants from Morcher and the Russian one called Repert, had the intraocular lens built up in the iris prosthesis, but the iris prosthesis is an opportunity for the patients, and this should be carefully evaluated case by case. He also mentioned about the problems of cataract surgery, especially in young aniridic patients. Young aniridic patients are prone to develop intraocular inflammation following the surgery. This intraocular inflammation brings a particular syndrome, which is anterior segment fibrosis. Anterior segment fibrosis is a membrane that grows on top on the lens and makes quite a problematic evolution of these cases in the post-op. So the advice is to delay cataract surgery in young patients with the cataract, to delay to the moment in which it is justified to have the surgery, as far as we have predictors of the outcome that we are going to have. That means to operate when we are going to have a substantial and significant gain in vision, and not just because of the cataract that is there. We have to remember that foveal hyperplasia exists almost universally and limits the vision indeed. And he gave several top tips about the surgery itself, which obviously were much more for surgeons, and we were discussing about the details of cataract surgery in this young age. In any case, it was a very interesting session. The malposition of the lens has to be corrected at the time of cataract surgery, which is an extra problem, because this makes the lens to be, the intraocular lens implanted, somehow less stable, and in these cases we agreed, and this was the opinion of all the surgeons that we were over there, that iris prosthesis are not indicated with lens malposition is there. So this was more or less the summary of this talk that was quite interesting, because cataract surgery, as I mentioned, is universally practiced in aniridia. Second talk was light management and vision correction with smart contact lenses. Professor Álvarez is a Colombian electronic engineer that works in Ghent University, and he and his team have developed a smart contact lens. This smart contact lens has particular capabilities that becomes opaque selectively with the intensity of light. that makes it possible to control the entrance of light in the pupil, and through a pupil that is virtual, it doesn't exist, but the contact lens makes, by this progressive opacity that develops concentrically and makes a pupil that up down to 1 millimeter, if necessary, to control the light. He saw in a CMAT software, which is a mathematical software in which you can reproduce the quality of retinal image in the retina, how much the quality of this retinal image was improved according to the decrease in the pupil size that provides this contact lens. Contact lens has a battery that has to be recharged every day, but indeed it's a great opportunity because, in my opinion, it's not only about the iris, which is one clear progress, but it's about the possibility to incorporate in this in the optics of this lens the particular devices that could implement the vision for near. In other words, we could have in the future not only the artificial iris, but also a lens that can offer a low vision aid opportunity to these patients on demand, which is indeed a great value. He announced that there's a company founded in Belgium to manufacture this lens. It is in the process to obtain the CE mark, and he is now expecting to have clinical trials as far as the specific law that is now for medical devices have changed in the last year, 2021, and this has delayed the production and the distribution and commercial basis of this lens. In any way, it's a smart lens that exists. It is patented, and in my opinion offers an important opportunity for the future of aniridic patients because the control of the light entering the eye, and also because of the optical performance that could be manipulated on demand as well to provide better near vision. Then we had one interesting lecture by Fabian Fries, and he talked about corneal transplant surgery and keratolimbal grafts. This particular topic is about aniridia keratopathy. You are very well instructed about how relevant it is because, in spite that we have cataracts as universal basis, we have an adequate approach to cataract surgery, but we don't have that much for a corneal transplant. Corneal transplant is frequently failing or failing in the medium term in most of the cases, and he was dealing about the pathogenesis, that means the origin and the reasons for this corneal disease, the aniridia keratopathy, and later on he dealt about the opportunity to have keratolimbal grafts and corneal transplant in these cases. It was a very specialized session. It is a session that is, or a talk that is very interesting. Probably in the coming future we should have one full session devoted to corneal problems in the aniridia, because this is one of the many of the most specific limiting factors for that could be treatable, but it's difficult to treat today in the aniridic patient. Paulo Rama dealt about anterior segment retinal surgery in aniridia, and this surgery is at this moment emerging. There are different options for regenerative surgery of the ocular surface based in the use of cells that comes from the mucous membrane of the mouth, also from the limbus, and also from iPSC, that means induced potential stem cells. All these three possibilities are in this moment explored. He could show some data about the outcomes that are present in 2 and 3 years in the cases implanted, and in general, we agreed in the session that this provides a transitory improvement to the patients. It might be 2, 3, 4 years, but it's not yet the final solution to the aniridia patient. Some innovative approaches are being used in order to make it more sustainable and less expensive as well, because it's a very expensive surgery, because the production is very expensive as well. And this is one way to the solution of the ocular surface problem in the future. There was a debate about the association of problems such as ocular surface inflammation, which is so much frequent, especially because dry eye is almost universal as well in aniridia, and this is one of the problems that faces this anterior segment, the ocular surface reconstruction, because the lack of adequate tear function makes this transplant to be unstable, and many times they fail because the lack of adequate tear film function, and also because of the associated inflammation. It was discussed as well, and this was a discussion that was taking place not only in the talk of Paulo Rama, but also of Fabian Fries, that the chronic inflammation that happens in the aniridic eye is or not necessary to be treated. It was somehow this different problems lead to a cascade of cytokine activation and substance P release, and probably it is one of the approaches to cancel selectively the substance P and also the cascade of cytokines by specific drugs. These drugs are at this moment under investigation, and the debate was whether it is worthy and justified to use on chronic basis in childhood topical steroids. Well, that was kind of controversial, and is not a clear evidence exists in favor of this use. It seems common sense to be used, but the benefits and cons of the use of topical steroids on long-term basis should be carefully evaluated by the clinician dealing with each one of the analytic cases to decide whether or not it's worthy and adequate and justified to use this type of medication in this basis. So this was about some of the talks. Let me go now to the second part. Okay, and we had in this second part one presentation by Pilar Casas de Guerra, this from our research group, about the phenotypic correlations in foveal aplasia and neuridia. She has performed a study that is in part published already, in which she tries to correlate the foveal hypoplasia with the visual performance of the neuritic patient. He showed quite an interesting study, very detailed about how these correlations from the morphology in OCT scan and the visual function can be estimated from childhood. So in very early cases in which we can today take the OCT scan of the macula, we can anticipate how much will be the vision of this patient based on the different types of foveal hypoplasia that can be diagnosed in these patients. Then we have another talk from Professor Peter Nedland from Virginia about the anuritic glaucoma. The glaucoma is one of the comorbidities that affect more frequently along the life to the anuritic eye, and the problem is how to treat it, because it is there are anomalies in the anterior segment. Obviously, we have the cataract, we have the iris, which is absent or nearly absent in anuridia. We have the ocular surface problem. That makes the ocular surface not to be happy with topical medication many times, and the natural fibrotic trend of the ocular surface of the anuritic patient. All this makes topical medication to cause some problems of toxicity in the long term, and glaucoma to fail in many cases because of the fibrotic reactions that block the filtration of the valves that are implanted. He dealt about the use of conventional surgery, specific devices, the microsurgical devices that are implanted today for glaucoma, specific surgical techniques that open the angle in the eye with glaucoma, and finally the use of new approaches to the treatment of glaucoma. In general, the agreement, and this was not only in the discussion that followed his presentation, but also in the contact that we had with Professor Nedland, it is agreed that intraocular surgery on the intraocular meshwork, in the angle that is formed between the remains of the iris and the cornea, is not indicated in the anuridia, that filtering elements based on the use of the microvalves, what is called MIGS approaches, is justified in some cases, but they provide a short-term control, and that valves, the conventional valves that are at this moment used, like the Ahmed valve and others, Breville for instance, are the best indication, and this should be performed when treated also the cornea. So we are going to perform a corneal surgery or a corneal prosthesis, that this topic that was not approached in the presentations of this during this session, indeed made an important limitation to the success of the corneal surgery, because glaucoma will make not only problems for the optic nerve, but also will and is one of the main reasons of failing of the corneal grafts and also keratoprosthesis. So these were more or less the approaches to the glaucoma treatment. There was total agreement that the medication should be preservative-free in the analytic patient with glaucoma, and that the different types of glaucoma that appears in the analytic patient were also discussed, from the congenital one, which is probably the less frequent, to the chronic evolution of the on the trend of to increase intraocular pressure, because chronic open-angle glaucoma is the most frequent type of glaucoma that happens in these patients. Other historical approaches to the understanding of why the increase in intraocular pressure in glaucoma happens along life were discussed, and he gave his opinion about which is the pathogenesis, that means the reason of the increase in the intraocular pressure along life in the glaucoma in the patient with aniridia. This is more or less summarize what we had, and let me give to you some other presentations that were also offered. José María Herreras, a colleague from Valladolid, he offered also the use of stem cells on the ocular surface. This was quite an interesting talk, because based on recent research that has been performed in Valladolid, the use of stem cells injected subconjunctival and also used even topical can increase the possibilities of survival of the corneal problems, the aniridia keratopathy in aniridic patients. This is under investigation. They are showing some animal models in which they are trying this therapy, and the use of stem cells from a bank of stem cells. It would be not only cheap but free of risk, and also could get important benefits not only to the keratopathy but also to the graft survival that happens to be limited, as you know, in the patients that need a corneal graft today because of the corneal problem in aniridia. He also agreed that there is no evidence today to use still this approach, but he founded his opinion about the recent investigations and the recent evidence that is raised about the use of stem cells from mesenchymal origin, both from the fat of the patient and also from the bone marrow, and their potential role in the control of the ocular surface problem, including dry eye and including keratopathy. Indeed, is open to a very, in my opinion, important and interesting future. Prof. Barraquer gave a lecture about cataract and the types of cataract that happen in the aniridia. It is very interesting, and he showed a tremendous amount of pictures about the tremendous mosaic of types of cataract that we have in aniridia. Virtually all types of cataract that are possible in the aniridic eye, and is definitely the organ of the eye that reflects more the changes that happen because of the genetic imbalance in the aniridia. The different aspects and the different morphologies, the evolution and the association to malformations, and also to misposition of the crystalline lens were shown in a very interesting and, in my opinion, well illustrated talk. This is about what we had. Giulio Ferrari from Vitale San Rafael University had a very interesting talk as well on the ocular surface inflammation. This talk was one, in my opinion, of the ones that really are offering more insight on what is the problem. You know, the problem is not the dry eye, not the keratopathy, is the reason why this happens, and he provided not only insights about what is the pathogenesis, the reason, the intrinsic mechanism, why the ocular surface becomes distorted and pathological in the aniridic eye, but also about the keratopathy, because all this is in the background of the ocular surface and corneal problem. This summarizes what was the session yesterday. The different talks were very well constructed. I want to congratulate all the speakers because they did a great job. They prepared very good talks, and as everything was recorded, you will have the opportunity to see these talks one by one. So I'm open to questions or comments that we have on these different talks, because as I was chairing the session with Professor Barraquer, we had discussions, we have private discussions as well in the coffee break, and all this is information that is available for you in this moment. So thank you very much, and the discussion is open. Okay, questions. I'm sure that you have many questions, please.
When you implant artificial irises and
Yeah, microphone, please. Can we have the microphone?
Thank you. When you implant artificial lenses and irises, do they have a specific life? Would they need replaced again?
Well, we have to remember that today, since about 6 months ago, we have a different environment in the artificial iris supply. You know, the artificial iris that we have now is made on silicone, is flexible, and doesn't have a lens. With this, we have to attach a lens to this prosthesis that will be according to the power that the patient needs to correct the residual refraction that happens when you remove the crystalline lens. This is one thing. Which lens to use is a monofocal lens. There is no possibility to use what we call today premium lenses that can give different levels of vision to different distances. We need to deal with monofocal lenses. Which one should be, in my opinion, hydrophobic lenses. Why hydrophobic lenses? Because they are less prone to problems that happen in connection with other surgeries, because they are not permeable to metabolites and not permeable to water, hydrophobic lenses. And hydrophobic lenses, 3 pieces, are the ones that I personally use in these cases, because we have to attach, to incorporate to the artificial iris the lens. So we have the lens, the iris, we have to put them together. Formerly, we have the lens and the artificial iris together, which was much more convenient. So the answer to your question, hydrophobic lenses of the power that corresponds to the one that the eye needs to correct the residual refraction that is left following the removal of the lens.
Thank you. Thank you.
Good. More questions? Yeah. Yolanda.
Hola, buenos días, profesor. No sé si están traduciendo en inglés, si no me responde a la vez en inglés. Sí.
Dilo en español y traduzco
sí.
y te respondo.
Gracias. Bueno, lo primero, esperar que ayer las consultas que tuvo con pacientes fueran suficientemente interesantes, con los pacientes que tuvo, tanto españoles como europeos. Y eso por un lado. Luego preguntarle con relación a la lente de Fries, esta lente inteligente, qué reacción, entiendo que es una lente exógena, si esa lente es exógena, si va sobre la superficie ocular, qué interacción hace con la superficie y qué efectos secundarios tiene, si comentó algo de ello el profesor. Y luego también quería comentar con relación a la inflamación de la superficie ocular, así en general, que se comentó entre los profesionales, si la cuestión de la inflamación, las causas de la inflamación eran una causa única y exclusivamente ocular, o sea, producida por la mutación genética, o también los cuidados externos de la persona, o los problemas metabólicos, o la alimentación, o el deporte, o cualquier otro tipo no de terapia, sino de tratamiento o de cuidado integral de la persona, influía en la inflamación o no de la superficie ocular. Tengo más, pero...
Okay, one by one. I have three questions. The first is about the patients that we examined on Friday. We had a total of 26 patients examined, and this was, I performed them all with Dr. Acasas, my collaborator, and was really a very exceptional opportunity to see a group of analytic patients that 26 is a lot. Remember that is 1 in 80,000 newborns, so you need probably one of them only seeing in his life only a couple of cases or 3. We saw 26 the same day. So this is really was an excellent opportunity. Each case was different. Each case was with its own problem, the different possibilities to solve the problem of the cataract that was present in almost 90% of the cases. Very young babies with a very obviously long lifespan to be aware of what is the preventive measures that we have to do, and we try to give advice to the patients, and we shall make a report to them just to give to provide the condition as far as we observe in the exam that we perform, and our advice just to be followed by their ophthalmologists in their own countries. What we recommended was that each one of them should be attended by specialized ophthalmologists, because one ophthalmologist can see 2 or 3 cases or 4 cases of aniridia along this life. This doesn't provide any highly specialized profile, right? So you need to go to a center when there is at least one ophthalmologist or a team that have experience in aniridia, because aniridia is a very specific problem. The second question is about the smart lens. The smart lens is at this moment just a device that has been created, has been tried, but has no medical trials behind, because nothing has been performed. And so the tolerance and the condition in which it interacts with the ocular surface has been so far investigated. We don't have information. But what is important, in my opinion, is to know that it exists. The speaker mentioned that probably this will be available in about 2 years, but the regulations that have to be accomplished will take not less than 1 year to make the first clinical trial. They have obviously make individual trials on particular patients, but healthy patients, just to see the stability of the lens and how the lens is providing the service that should be offering to the eye. But there is no clinical information and no information about the ocular surface performance following the lens. And about the third question, Yolanda, about ocular surface, this is a great debate, how to handle. Is there any influence of the diet, any influence of the style of life? Probably there is, but it's not the reason of the problem. The reason of the problem is the aniridic pathology that exists in the ocular surface and especially in the cornea. Dr. Ferrari is here, and probably he can make a point, because there was one of the presentations that I like a lot. Could you like to make a point about the ocular surface for our patients to understand better where we are, Dr. Ferrari?
Well, yes, I think, as I said yesterday, one thing that in my opinion emerged from the presentations that we see is that inflammation is starting to emerge as perhaps a key aspect of the pathophysiology of aniridia. So we have indirect evidence, we have always had it, that like these patients had clinical pictures which we normally see even in patients without aniridia but with chronic inflammation, such as like meibomitis, dry eye disease, and neovascularization. I mean, the clinical picture is highly resemblant of a chronic inflammation of the ocular surface. So what I and others are trying now to understand if this is in fact the case. So there was a presentation yesterday showing that in fact there is a panel of pro-inflammatory cytokines that seem to be increased, at least in the early stages of the disease, which opens up the question whether there may be a window of opportunity for treating these patients perhaps in an earlier phase before we start seeing like the clinical signs of inflammation such as epithelial defects, etc. And well, in particular, of course, there are a number of pro-inflammatory molecules that could have a role. We have studied in specifically some that are related with neuroinflammation and which we believe could help explain why these patients many times have present at the same time nerve damage, corneal nerve damage, and persistent inflammation. And I think that ultimately this could also help us to understand why in the long term these patients develop limbal stem cell deficiency, while it is not still clear if limbal stem cell deficiency is a cause or a consequence of aniridia keratopathy. Still it happens, at least in a subset of patients. So what we believe is that perhaps if we manage to control inflammation, which happens over years, and we manage to intervene in an early phase, we could perhaps stop this cascade which over time brings to limbal stem cell deficiency. So I would say that I would see in clinical terms a role of like prevention of more serious complication in controlling inflammation early on in the disease.
Yeah, that's it. So I totally agree. There is an inflammatory background in ocular surface in the anuritic patient. There is very consistent evidence. The problem is how to treat it, because associated to this inflammation that is obviously toxic for the cells of the ocular surface, we have now apoptotic trend. That means a trend to die of the stem cells. And this combined makes the problem. Yolanda, more questions?
Ya quería seguir tratando el tema este de la inflamación, porque me resulta de interés el pensar que hace años no se hablaba nunca, no se relacionaba nunca el ojo seco con la aniridia. Hay personas con aniridia que están diagnosticadas además de ojo seco, pero otras no. Y sin embargo ahora empezamos a ser diagnosticados de ojo seco. Entonces se nos trata como ojo seco porque somos propensos a esta inflamación permanente, y es el ojo seco el que provoca la insuficiencia límbica, o es al revés.
So the question of Yolanda is,
y por ejemplo, lo que es el tratamiento, en lugar de ser medicamentos, podrían suplirse tratamientos preventivos o utilizarse tratamientos preventivos mientras que la inflamación no provoca reales alteraciones corneales, y utilizar plasmas ricos en factores de crecimiento, por ejemplo.
yeah, you know, the question of Yolanda is about the dry eye. Dry eye was formerly almost ignored in aniridia. Actually, if you read the textbooks, and it is not even mentioned in many of them. That means that it's a new element of aniridia syndrome. I do think that it's a new part of aniridia syndrome under-scored and under-recognized before. This is my opinion. In the 26 patients that we saw before yesterday, not less than 2/3 of them had dry eye. And this is not because only the children were not with dry eye, but most of the young persons, we dealt with persons with 15 to 16 and beyond this level, had at some degree of dry eye. We didn't perform a specific exam of the dry eye because we didn't have the time for that. It's something that it has to be specifically performed, but I'm sure that they have a tear field dysfunction. Why they have, I don't know, because it is still something that we are discovering, okay? But this dry eye is related to, is causing chronic inflammation and might be related to a chronic inflammatory condition of the aniridic eye, which is probably what happens. It's a positive feedback that starts with low degree of inflammation, chronic in the cornea and the conjunctiva, leads to more inflammation because of the damage, and this chronicity makes the problem. The second part of the question of Yolanda is about prevention. Should be treated from the beginning, even that is not a dry eye, but can be prevented by treating. I don't think we have the evidence to answer this question. We don't know. You know, should we use artificial tears in order to make a more lubricated ocular surface in childhood? Probably yes, but it is necessary. Not evident, you know. Which are the best ones to use? Because all medications have toxicity. Obviously, if they have preservatives, it's even more toxic. So we have to be sure that what we use is justified. Probably we need to use this medication with any minimal evidence exists, and about the use of other medications that could be useful for the purpose. For instance, and specifically corticosteroids should be carefully evaluated by the clinician, because corticosteroids have other side effects that, if they appear, can make the life of the aniridic patient even worse. So I think that it's difficult to answer specifically to your question, Yolanda, but I think that the answer is early diagnosis is necessary. We have the ways to make an early diagnosis of dry eye, and it's different types, because dry eye is just a generic name behind which are many types of dry eye. And to treat each type of dry eye with a specific medication that is the more adequate for it. Which is the one that is more adequate depends patient to patient. And in my opinion, I again tell you that dry eye is a part of the syndrome that complicates more the corneal problem and complicates more the glaucoma problem as well, because the glaucoma is treated with medication that has direct toxicity in some cases and indirect because of preservatives in the aniridic eye. I am answering to your question, Yolanda. Okay, thank you. Yeah.
A question. So this is very interesting. Also, Giulio talking, and you're talking about inflammation. Of course, we know that inflammation is part of aniridia in the cornea, especially even at a young age, even though you may not see it clinically, but it's there. And of course, there may be a treatment window for this, but the problem is what to treat with, and there is no approved really anti-inflammatory drugs. But a lot of patients with aniridia are taking autologous serum, for example. So would there be, I mean, there's a lack of scientific evidence, of course, for this, especially at a young age, but could it be something to look into maybe at a younger age, starting to take autologous serum to perhaps delay or suppress the inflammation at an earlier stage before maybe the dry eye symptoms start to appear, and perhaps delay also, the degradation of stem cells. It's difficult because maybe we don't even know everything that the autologous serum is doing. It has a lot of factors. Maybe some of them are anti-inflammatory, but some could also be harmful, perhaps. And especially taking it at a very young age for a long time. I don't think any studies have been done on this, but I don't know what is your feeling about that?
Yeah, well, I think that you make a very good point. The use of hemoderivatives, that means autologous serum, platelet-rich growth factors, or platelet-rich plasma. We described for the first time the use of platelet-rich plasma in ophthalmology. So we have probably 8 or 9 papers on this topic, and it's an extremely useful tool when you have a corneal erosion, when you have a disruption of the surface, either at the conjunctiva or the cornea. I don't think that is necessary before that, unless there is any study that supports that it prevents the development of the problem. Might be that it's good to prevent, but we don't know. Basically because we don't know why this dry eye happens such an early age and with a moderate type of severity, because severe forms happens in the middle age to age patient, but not in very young. Platelet-rich growth factors is about the same, but the difference is while in PRP, platelet-rich plasma, the platelets are activated with the contact with the ocular surface. In PRGS, they are broken a priori. We think that it's better to have the platelets and to activate it on when they are provided in the eye. Seems to be a much more adequate and elegant way to provide. But both methods, in my opinion, are giving about the same results. About autologous serum is clearly inferior to the other two elements. Autologous serum is with almost free from active cytokines, and is definitely not that bioactive as PRP or PRGF. It is a good lubricant, but beyond being a good lubricant and to some extent a bioactivator, is not a bioactivator itself. So if I use in aniridic patients, or in any case in dry eye, PRP, I use PRP, I abandoned autologous serum about 10 years ago. I don't use it at this moment. And on the other hand, the results, in my opinion, are better. But I use when we have a disruption of the surface of the epithelium, either of the cornea or the conjunctiva. We don't use it as a preventive measure. Might be used, but we don't have any evidence to support. So again, the problem is when to treat and with what to treat. But you have to leave time for the investigators and the evidence to raise the evidence to support what has to be used. There are many molecules in the market that are good as well. Tealos, for instance, is a very good product that can be used, is commercial, and probably for those that have not a relevant form of dry eye, might be the first approach. So probably we have a first line with medication that is commercial and good quality and selectively protects the epithelium and has some good lubricant capabilities. And then we have a second line in which we need to use therapeutic products in order to treat a disease. Yeah, there is a question there.
Have any corneal sensitivity studies been performed in aniridia patients? They are more sensitive to cold or to mechanical stimulations?
Yeah, I have read different papers. I don't have that experience, but in my experience, there is a hypersensitivity of the cornea. There's hypoesthesia. The problem is that we don't have good tools to measure, that in clinical basis, the sensitivity of the cornea. But if you use the Cosebone device or the air pump devices, they always tell you that you are dealing with a hyposensitive cornea. So the answer is yes. But as you know, this is universal in dry eye. So probably it's something that comes with a dry eye, and might be part of the reason of the dry eye. And this is the debate: is dry eye and neurologic disease of the cornea? Might be that there is a company. Then in some cases, in the severe cases, you always have this problem. In the intermediate cases, sometimes I don't see this problem of hypersensitivity in low degree dry eye.
Thank you.
More questions? Well, we are almost in the limit of the time that we have for this session. Any other about glaucoma? Nobody has questions about glaucoma? Yes?
I would like to ask you about the cyclodestructive procedures for glaucoma in children. What's your point of view about that?
The question is about cyclodestructive procedures. There are procedures that with lasers and specific wavelengths we destroy, we treat the glaucoma, decreasing the production of aqueous humor. As you know, all these procedures are destructive by definition. So my personal opinion is that I use them as the last approach, because they cause macular edema and they cause visual loss. And the last thing that we want in adult patients is to cause further visual loss. So I use in almost blind eyes when we have a very advanced glaucoma, and the consensus is about cyclodestructive procedures are to be used as a terminal stage in glaucoma treatment in these very delicate cases. There are other options of treatment with threshold cyclodestructive procedures, which are being used, but the evidence that we have at this moment is conflicted. Sometimes they work, sometimes they don't. They are working in temporal basis, so they can last for some months. Doesn't seem to be the solution for the aneurotic patient. Endocoagulation has been tried, and I did as well. And again, the same problem. The destructive is much more elegant because you don't destroy the ciliary body without seeing when you are applying this laser energy. You look at the ciliary process and you coagulate specifically then, and they are visible in aneurysm very, very easily by endoscope. But the problem is that you can decrease the pressure for 3-6 months, and then you have to repeat it, unless you use very high levels of energy in which you induce inflammation, intraocular inflammation. They are not the solution. They have been investigated for the last 15 years, and still the debate is there, so they are not working. So they work on temporal basis, and I use only in end-stage glaucoma cases, because the reasons I mentioned, they have the potential to induce visual loss. Okay, Yolanda has more questions. You always have many questions.
Sí. Solo dos. A ver, profesor, con relación al glaucoma, tanto el congénito como el resto, quería saber si se había debatido en algún momento entre los ponentes a partir de qué momento empezar a instilar colirios, beta bloqueantes o cualquier otro tipo de producto para controlar la tensión, teniendo en cuenta el grosor de nuestras córneas. Eso por un lado, si había algún grado medio de presión ocular con el que empezar a actuar realmente, o solo era caso a caso. Eso por un lado, o también dependiendo del problema de la córnea, como estuviera en ese momento con ese paciente de glaucoma. Y luego otra cosa, ¿qué era la otra cosa?
Okay, think about that, and I am answering first. Okay, now it's about when to treat glaucoma in aneurysm. When to treat glaucoma in aneurysm. What is the threshold of pressure when you measure the pressure that gives the key to open the glaucoma treatment? Because think that the cornea is thick in aneurysm, and this thick cornea overestimates the pressure. But we have tables to calculate what is the real pressure. The answer is we have to decide patient by patient. It might be that 22 is too much for one patient, and is not, correct the cornea, and is not that much for others. Depends on the age, depends on the comorbidities, and depends on the family history. These three issues make the treatment of glaucoma or ocular hypertension on a particular basis, case to case. But you have to consider, in general, in glaucoma, we treat when we have intraocular pressures beyond 21 corrected, okay, for cornea, and and also with some evidence or risk factors, because it's not the same to have 21 than 31. In general, more than 26 is treatment, clearly. More than 22 is to consider treatment, and 21 or less is no treatment and observation in general. Other question?
Sí, ya me he acordado. Con relación a los trasplantes de córnea, trasplantes de limbo, trasplantes de lamelares, trasplantes penetrantes, si se habló de algo de esto y si se llegó a alguna conclusión en cuanto a qué es lo mejor, qué es lo peor, si hay alguna tendencia ahora mismo con respecto a otros años, hace 5 años que era otra cosa distinta, vamos.
Yeah. Now it's about corneal transplant and limbal transplant. Very important question. About limbal transplant, there was in one of the presentations evidence that provides clearly that there is no difference in the corneas, in the limbal grafts transplanted from the second eye of the same patient than from a donor. This is interesting because we always consider that autografts should be more successful, but autografts have one problem. You take the limbus from the other eye that will not be healthy in the future either. So sometimes you can promote the disease. I have this experience, and believe me, in my cases, doesn't work. Doesn't work because the eye of that provides the tissue suffers from inflammation, and then you worse the good eye of the patient, so not to be done. But as far as this study was on, there was not an indication, because allografts, which are grafts taken from a donor, gives this, with immune suppression, at 3 years have the same rate of success. The rate of success announced was 85%, according to that study. It is my opinion that is much less than that. So to have a successful limbal graft over 3 to 5 years is exceptional, and many of them fail in the early stages, in the 1 to 2 years. The reason is always the same: dry eye and inflammation. Dry eye and inflammation. So limbal grafts are still there. Then the use of stem cells injected in the subconjunctival space is explored, but there is no evidence at this moment to support that they work. Probably they will work for a while, and no more information is provided. So the conclusions are allograft tissue is the one to use. Second, immune suppression for life, bad news, but this is the case, especially for young people. And number 3, we should expect a survival of about 5 years in the best scenario. About corneal graft, laminar grafts are always better than penetrating grafts. We know that. And in Iridia, one of the largest, probably the only one that is not affected is the corneal endothelium, right? So as far as the corneal endothelium is healthy, and we know that on clinical basis, laminar grafts are better indicated. But laminar grafts should be deep DALK, deep anterior laminar grafts, because to leave part of the cornea of the iridia, which is the problem of and the cause of the disease, is not a good practice. You know, we need to go down to the descent membrane to peel all the tissue and then to put a new one. Probably this graft will be alive, let's say, 4, 5, 6 years as well. The opacity happens. The main problem of this graft is the development of corneal ulcers, what we call chronic epithelial defects, or dormant corneal ulcers. This is the evil of the corneal transplant, because the cornea is transparent, but then we have lack of innervation. This lack of neural stimulation of the tissue is the problem. This leads to chronic epithelial defect, very difficult to treat. We use platelet-rich plasma, PRP, successfully to a certain extent, but this is the beginning of the story. After the cornea will become progressively opaque, and finally will become opaque, and then a new graft is necessary. Meanwhile, we have the vessels growing from the periphery that we need to treat. There are different approaches now with the use of anti-VEGF, vascular growth factors inhibitors, that can control to a certain extent these vessels to grow from the periphery, but this needs almost a monthly care to the patient. So those that take a corneal graft, again, they should go with specialists, but they have to be aware, the patient and the doctor, we need to have frequent checkups. Could be monthly, 3 months, but not less. Yolanda, next question. Nothing. Okay. Very good.
Muchas gracias.
Thank you. Any other question? Nothing? Well, thank you very much, and it has been very interesting for us as doctors to be interacting with you, and I'm sure that you will find some light in this tunnel in which the neuritic patient eye, because there is light at the end, you know. Clinical research is being produced, scientific knowledge is increasing. We have new molecules that in the future, probably in the next 5 years, could unveil the potential application of medical therapy of the patient with anuridia, especially in early ages. And finally, we have specialized doctors in Europe with this network that was so well explained yesterday, that guarantee a perfect, excellent service to the state of the art of the medical practice at this moment. So thank you very much, and happy to close this session. Thank you.